Hello, hello, good morning, good afternoon, good evening to everybody here. Welcome to another CP Solvers Residency VMR. Today we have a very special presenter at Norwalk Internal Medicine Residency in Connecticut, and we have to proudly say that one of our CP Solver members, Marino, is going to be presenting the case. So, Marino, would you like to introduce yourself and tell us what you like to do for fun?
Sure. Well, guys, I'm Marino. I'm an intern at Norwalk Hospital. I've known this hospital for a very long time. Luckily, my brother was a resident too, so I'm very pleased to have joined that program as an intern. And I'm also very proud that I've been a member of the CP Solvers for the last 2 years almost. In terms of what I want to do, what I like to do for fun, I like to play video games and read manga. That's basically it. Sometimes I like to hang out, but now it's too cold for me, to my liking, and to what I'm really used to. So I'm just adjusting at this time.
Yeah, Marino, he was just telling me before we started the session that it's snowing over there. So
Yeah.
nice, very nice. I also have today two of our discussants, CP Solver junior members discussing today. Anmol, would you like to go first? Please introduce yourself, friend.
Hello everyone, my name is Anmol Preet and I'm a proud CP Solvers member. I'm an international medical graduate from Punjab in India and I feel very honored and I'm very excited to discuss this case today with you all.
Thank you, Anmol. And our second CP Solver discussant today is Raul. Would you like to introduce yourself, Raul, and what you
Hello,
like doing for fun?
everybody. Yeah, sure. Hello, everybody. I'm an international medical graduate from Hyderabad, India. I'm currently in Connecticut in Hartford City. The weather is really good today. Yesterday it was snowing here, and I'm excited to learn from Marino's case today and excited to discuss the case with Mingyu and Anmol. And outside of medicine, I love cooking Indian food. I made some good curry yesterday, and I'm planning to make something today. And I love doing meditation and yoga too. Thank you so much.
That's really cool. If I'm not wrong, so I'm you're from the north part of India and Raul from the south, right? So we have whole India here. Yay! And last but not least, very important, today our attending discussant, Dr. Mengyu. Dr. Mengyu, please introduce yourself and tell us what you like doing for fun.
Yeah, hi. So blessed and so humble to be here, and very excited to be co-discussing with Anmo and Rahul, and also learning from Marino. I heard it's a really mind-blowing case, so I can't wait to to learn about from that case. But yeah, thank you for having the session. I think outside of medicine, I just I have 3 kids, so I spend a lot of time with my family. I think that occupies my time outside of medicine. But yeah, thank you.
No, that's really cool. I know Dr. Mengyu won't say it out loud because she's really nice and humble, but she's like Wonder Woman. She has 3 little kids and she's also a hospitalist and she does everything. So honestly, wow. Like I it's amazing. So I think that before we continue, remember at the end, instead of TPs, we will have a little small Q&A session. So stay till the end, friends, and we can start with the case. James, whenever you're ready to share your screen.
Sure, just a moment.
Of course. Thanks, James. Who, by the way, shout out to Shema. She just graduated. She's a whole doctor now in Germany. That's amazing.
Let me know when the screen is ready, please.
Of course. Of course, of course. I'm really nervous too. Like,
I haven't been sharing my screening a lot, as you can see. That's why just a moment.
oh, no worries, friend. No worries. It's adding to the.
Maybe is someone able to share?
Oh,
just
I can.
share the screen. Oh, okay. Mariana can share.
There you go. Whenever you're ready, friend Marino.
Okay, so let's start. Just a disclaimer, this is a very eye-opener case that we have about 2-3 months ago in Norwalk Hospital. And I just want to share in the journey. I'm not gonna give all the details because it is going to be probably a 2-hour long case if I do that, but let's keep it short and sweet. So chief complaint is cough and shortness of breath on exertion. And let me just give a brief HPI. So this is a 38-year-old man who came to the hospital with cough and shortness of breath on exertion for 1 month. Patient states that he was in his usual state of health until approximately the first week of September, when he started to have coughing spells, and shortness of breath with exertion. He described the cough as episodic, intermittent, and dry, and he had coughing spells 5 to 6 times per day that lasted around 10 to 15 minutes. This cough would have also been preventing him to sleep. Regarding the shortness of breath, he states that he was having difficulty breathing every time he went for a walk or performing. As long as going up the stairs, he was feeling very short of breath. These symptoms continued to progress for 2 weeks, so he decided to go in for a walk-in clinic, and he was prescribed azithromycin for suspected acute bronchitis. Even while completing the antibiotic course, his symptoms persisted, and he decided to go to the emergency department, where he was diagnosed with pneumonia at that time, and he completed a 7-day course with cefpodoxime and azithromycin again. Unfortunately, the patient's symptoms got even worse, and these were associated with fainting episodes related to the paroxysmal cough episodes. Then, this prompted him to visit the ED, and this is where the journey starts. So, if anyone wants to jump in of the discussants and give us your thoughts.
I think that's a very wonderful aliquot. Thank you, Marino, for that. The chief complaints are very interesting. We have a young male coming with shortness of breath and cough. If I just talk about the shortness of breath pyramid, which we have, the main things, the two organ systems which we target is lungs and heart. But in this young patient, I would definitely want to rule out the lung causes. If a patient per se comes to me with these complaints, I would love to auscultate the chest. Why do I say that? Because when now the main complaint they say is that the cough is dry. If the cough is productive with expectoration and the patient comes with shortness of breath, the first differential of which comes is acute decompensated heart failure, and we hear bilateral creps on auscultation. But I think the cough is dry in this case. So if I think about the pyramid, it has the lungs causes, the heart causes, then we have anemia, psychiatry causes, and neuromuscular weakness, which can lead to shortness of breath. The main complaint is that the patient has shortness of breath on exertion. So that if I think about a cause from the heart, then I can think that probably it is raising concerns for a heart issue as well. So we cannot actually rule out a pathology in the heart. But then if I see the next history, which reveals that these spells, they are enough to cause syncope in the patient or the fainting spells. So why does that happen? Is that because of a low blood pressure? That is very important to rule out what is the cause of those fainting episodes. And I think the patient did not respond to the treatment for lower respiratory tract infection, pneumonia. I think the ceftriaxone and azithromycin, they did not work. So we have some other working diagnosis. What I would like to go for next would definitely be auscultating the chest, getting a chest X-ray, and then I think we might need a CT as well. Now, since the patient is not coming to emergency, so we presume that the vitals, they are normal. That's what I have been able to make out from this aliquot, and it's really, really interesting. What do you think, Rahul?
I really liked your approach to the systematic approach, your shortness of breath and with associated cough and more. I really appreciate that. I think honestly I don't have much to add, but I really want to focus on the pattern of cough. The cough is, as you mentioned, it is associated with some paroxysmal cough, And I'm just wondering, and also he also got a treatment for pneumonia, but still he did not respond to the treatment and he came to the ER and he's not able to sleep. As you mentioned, it could be a both like upper respiratory tract infection or any lower respiratory tract infectious process like pneumonia could be possibility, but also this is an young, I think middle-aged man with subacute to chronic history of cough, shortness of breath may always make me wonder to think of pneumonia mimics like vasculitis. So that could be a possibility. And also I'm just wondering, is it something related to any infectious process? I still remember at least in the textbook presentation, like any infectious process like Bordetella sometimes causes this kind of the coughing spells with associated fainting. And that could be a possibility, that could be infection process, or it could be any inflammation. And also, and looking at the patient cough is disturbing so much, he's not able to sleep. I just want to take more, I just want to dig into more history in such a way that whether he is having any shortness of breath while sleeping, will he having any congestion in the chest that could, preventing him from sleeping, like orthopnea or any kind of PND, which will really help me in navigating the case to think of either to put the pulmonary pathologies in the top differentials and then followed by the cardiac pathologies and looking for any other associated symptoms like any edema or any kind of abdominal distension or yeah, something like that. So those are my thought process. As you mentioned, it could be both the cardiac pathology or pulmonary pathology, and I strongly believe that the kind of any significant past medical history and as well as the lab, the auscultation would really help this patient. And I just want to add one point here. I really want to dig about more about his social history, about his smoking history, and more importantly, the history of vaccination, because it has been started in the month of September, which is flu season. I really want to know whether he's taking his flu shot, whether he got all vaccinations according to CDC recommendations. So those are my thoughts. And yeah, I just want to hear Mingyu thoughts as well. Thank you.
Yeah, wow, I'm so blown away by your discussions. In this CP Software space, I feel I always learn more from our members, and then more I could offer to teach. But yeah, so thank you for sharing your thoughts. I kind of think along the same line. When I first heard about the significance of this cough, I was because like we see shortness of breath quite often in our cases, and for that I agree with like focusing on heart and lung and some others like blood like acid-base problem. However, here with the cough, it almost kind of helped me localize it to the lung and the airway specifically, because I translate cough into airway irritation. And while the most common causes of cough, like we see like in the clinic, are like something like GERD or asthma or upper airway drip, postnasal drip kind of physiology. And sometimes also like chronic aspiration or smoking or ACE inhibitor. And here I think that the addition of the shortness of breath really kind of localize that to the lung and the airway, which makes me think wonder is more like intrinsic to the airway, such as like tracheal or bronchial lesions or inflammations, and also expand that to think about like some external compression that irritates the diaphragm or the mediastinum, for example, like includes like things in the lung, so that's above the diaphragm, or even things under the lung like spleen or liver problem that could irritate. But I think with the shortness of breath, probably thinking more something above the lung, above the diaphragm, in the lung, and involving the irritating the airway. Yeah, those are where my thoughts are. I can't wait to hear more of the case.
Wow, I'm very mind blown of how much you can get out of a single aliquot, and I'll give you more information as you request. So let's start first with our simple review of systems. So patient has been complaining of diaphoresis for the past 3 days before getting to the ED. He's been having some discomfort while passing stool. He reports intentional weight loss for the past 6 months with a low inflammatory diet. He's reporting fatigue and also weakness. There's no orthopnea, no paroxysmal nocturnal dyspnea, but patient has been saying that it's been getting very difficult for him to sleep because of the cough. Other history. So patient has a past medical history of asthma, a past medical history of Epstein-Barr virus infection. His medications are gabapentin and naltrexone, although for the past medical history, he also says that he has a questionable history of rheumatoid arthritis. He went to get workup, but he never got any joint swelling or something, so they decided to not proceed with more workup at that time. Also, another important history, recent travels. Patient traveled to Bermuda 1 week ago before the symptoms started. For the work-related part, patient used to work in a plastic industry before all of this. And social history, patient states being a social drinker. He used to vape. Last time he vaped was 8 months before the visit, and used to smoke marijuana about 10 years ago, and he stopped smoking cigarettes in 2020. So with this data, what can you get off now? How can this narrow your differential, guys?
So, Anmol, do you want me to jump in, or do you want to handle this helicopter? Yeah. So as far as, the great review of systems, I really don't know where is Bermuda, to be honest with you. Is it in the Caribbean islands?
Yeah.
Yeah. So sorry for that my ignorance. As far as the diaphoresis for the 3 days and discomfort while passing stool and unintentional weight loss for the past 6 months, I really don't know whether the ongoing history is contributing to the present 1 month complaint. And also, I really want to dig more into the discomfort while passing stool. Is it like a cramping abdominal pain, or is it like any kind of like any anal fissure or any kind of constipation causing the discomfort? And I'm just wondering, how could a problem running in the pulmonary pathology, let's say the lower respiratory tract, could affect the abdominal pathology? Or else, is there any ongoing systemic inflammation which is affecting the entire gut, or affecting the like lower respiratory tract system? That could possibility. And weight loss, as far as weight loss is considered, I always, whenever I hear about the unintentional weight loss, I always think about malignancy as my top differential. But I really wanted to dig into his nutritional status and how is he eating, like drinking okay for the past 1 year. And also sometimes like systemic inflammation sometimes do causes this kind of weight loss. And traveling to the Bermuda 1 week prior to the symptoms, I'm not sure, because the symptoms has been going on for the past 1 month. But let's say, for example, this has been going on for the past 6 months or 1 month, and the top of that, he had any super added or a ongoing infection or inflammation, which is aggravating the symptoms and making the patient to come to the ER. So that could be a possibility. And I just want to add one more point on his past medical history. He had a questionable diagnosis of rheumatoid arthritis, and his occupational history of working in some plastic industry. That's what yeah. So I really don't know whether any kind of like autoimmune inflammation is instead of affecting the joints, maybe it's affecting the lungs. Like it could be because of the rheumatoid arthritis mediated lung injury, or any kind of occupational history contributing this kind of complaints. So those are my thoughts.
Yep. Wonderful, wonderful thoughts, Rahul. And yes, so many risk factors we have in this aliquot. Number one, we have asthma. So we have to see if it's acute exacerbation of asthma, which might not be the case, but we have to look for visas once the patient presents to the clinic. Then we definitely have the history of vaping. We have the history of smoking. I always believe that once we are in the hospital setting, there is not just one diagnosis which is responsible for all the symptoms. Every single thing contributes. So the rheumatoid arthritis history has also implications with the lungs as well. If I remember correct, there is some association with Kaplan syndrome, which can be associated with rheumatoid arthritis. Some form of interstitial lung diseases can be associated. The travel history is also one of the risk factors, but then it raises concerns for some sort of infection, travel-related infection, or pulmonary embolism. These symptoms don't look like that, but definitely we have broadened our differentials with all the risk factors. And yes, excited to see what comes next. What do you think, Dr. Menke?
Yeah, wow. I don't have too much to add. I agree with all your analysis. I think definitely the rheumatoid arthritis brings up a lot of possibilities, as you have mentioned, in terms of pleurisy and involving the Kaplan syndrome, and also the plastic, the combination of that and with the occupational exposure. And the occupational exposure itself can be associated with certain ILDs, which can be featured by cough. And also the plastics also makes me think of about like certain like pleural plaques or mesothelioma maybe. Yeah, I think such a rich past and social history here. I
Okay,
think some imaging would help us move forward, but yeah.
amazing discussion so far, guys. So let's give you some physical exam findings, a little bit of labs, and some imaging to narrow more your diagnosis. So for vital signs, patient came in tachycardic with a heart rate of 106, blood pressure was 127 over 82, respiratory rate was 22, and patient was saturating at 94% on room air. In terms of physical examination, the only pertinent positive the patient had was periorbital ecchymosis and subconjunctival hemorrhage due to the coughing spells. Lungs were clear to auscultation bilaterally. No abnormal sounds were heard. Patient had a regular rate and rhythm, no audible murmurs, S1, S2 present. Abdomen was soft and non-tender, while bowel sounds were normal active, and patient didn't have any lower extremity edema. In terms of labs, patient had a white count of 15.1, hemoglobin was 13.5, platelets were 483, chemistries were all within normal limits, NT-proBNP was less than 50, CRP 106, EKG was showing sinus tachycardia, and I know Jazz has the first X-ray, so if you're able to show it, and then I can read the official radiology report. So if you want to tackle in first the chest X-ray, and then I can give you the radiology report, or if you want me to give the radiology report now, as you wish.
Yeah, I think we can just say one sentence what we see inside that. But I think there I see the blunting of the costophrenic angle on the right side. So definitely the chest X-ray is not normal. That's the first thing, and there is I see opacification and probably maybe some evidence of cardiogenic or not cardiogenic, but maybe non-cardiogenic pulmonary edema. That's what I'm thinking, but I'm not that good at reading X-rays. If Rahul or Dr. Mengu has something to say.
Yeah, I really loved your thoughts, Anmol. I'm just wondering, I mean, I'm just seeing some kind of hazy patch over the left lung surface. And also, yeah, I really don't know what could be the technical term, but and also some kind of I really don't know whether it's called ground glass opacities, but it kind of infiltrates throughout the lung parenchyma. And yeah, those are my thoughts. And
Yeah.
I'm so sorry. Go ahead, Maggie.
Oh no, go ahead, Rahul. You
I
were gonna
really
ask.
don't know whether the trachea is it because of the position of the patient or it's deviated somewhat to the right side. Yeah, but I don't. Yeah,
Yeah, I love your thoughts. I think at first what really jumps out to us is a bilateral infiltrates, hazy. I wonder, yeah, well, also wonder if we could call it a GGO. I think a CT scan would help clarify, but if it's GGO, we could think about the differentials for that, like what is filling the lungs. I think so. Next step, I think, is a CT scan for sure. But also, I agree with Rahul. I thought the airway looks a little weird. It may be position, but I think the CT scan will help clarify. But I wonder if there's even some narrowing in the trachea there on the left side, which would points towards some endotracheal lesion, but I'm not sure. I'm not convinced at all about that. I think really the bilateral lung infiltrates is what we're going to focus on with our through our imaging to get more clarification on that. But yeah, I think we
Yes,
can talk more down the road about like what could be, if it's GGO, like what could be feeling, and there are like different causes for that.
yeah. Sadly, in the radiologist read, they didn't tackle in about the trachea, but the official read is diffuse lung consolidation worsening in the lower right lung and stable elsewhere. And also just wondering what is your opinion regarding the set of labs and the physical exam on this patient, and then we can give more data about the CT scans and what happened after this.
Yes, I think the labs actually show an inflammatory signature with the reactive, I hope, reactive thrombocytosis and the leukocytosis. Also, the CRP seems to be raised, so definitely there is some sort of inflammation going on in the body. If it is not the correct microorganism we have recognized, if it's not pneumonia, there is something inflammatory going on inside the body. That's for sure. And sinus tachycardia is also looking like a stress response to that. Otherwise, if you take a typical history of a patient with the travel coming with sinus tachycardia, we definitely want to see on POCUS if the RA or NRV are dilated. Then it just rules out in some part that the pulmonary embolism picture, but that we can do with the POCUS echo. But I believe that there is something inflammatory going on inside the body. And I'm not sure if there was any history of fever. Maybe we missed that, but yeah, that's what I'm thinking.
Loved your thoughts on Mole regarding the white count and the sinus tachy and the other findings. I'm just curious if just looking at the saturation, for example, if I'm seeing this chart reviewing this patient in the EMR, and because the patient came to the ER with severe shortness of breath and is unable to sleep, and I would expect a lot of desaturation. But this patient is maintaining the saturation of 94 under room air. I'm just curious whether his lung tissue is having, undamaged lung tissue is coping up the oxygenation, which is maintaining his 94% saturation. But I feel his heart is working so hard to maintaining the metabolic demand, as you mentioned. And also he's having tachypnea of 22, but he's not having, because rest of the general findings is fine, he's not having any use of any kind of exacerbation of respiratory symptoms, like using of having nasal flare, using scalene muscles and abdominal grunting. So the symptomatology is much more severe than the saturation. And as you mentioned, because there is a bilateral infiltrate, and it could be because of any possibility of rheumatoid arthritis mediated inflammation, or any something related to the occupational history, or given the history of asthma. And there is other possibility of other I was reading about the ABPA, allergic bronchopulmonary aspergillosis, which could precipitate this kind of symptoms. But I'm just still wondering, I never saw a patient back in India or here with patients with this kind of etiologies would cause the coughing spells leading to the hemorrhage. And I'm just wondering, am I really going very aggressive in thinking of inflammation process? Am I really missing any kind of infectious? So still there is a possibility of infectious bucket in my differentials, but I really want to consider those inflammatory factors too. Yeah, those are my thoughts. I want to hear your thoughts, Dr. Mingyu.
Oh my God. Yeah, you guys are awesome. I don't have too much to add, but I will say, yes. Oh, I think for the white count, I love to know the differential. I think presumably it's a neutrophil predominant because that would reflect the degree of inflammation as you all suggested. But I just want to make sure it's not eosinophil, because I remember there was a case where there was like parasites infiltrating. So I was like thinking about the travel history exposure, if there's anything like that. But if it's neutrophil, then we would just go down with the direction about the inflammation. And then in terms of, yeah, I think you guys touched upon some of the really concerning or possible causes of this, what's filling the alveoli. It could be like past like infection that we kind of mentioned or empirically treated earlier, or like Rahul, you mentioned, could this be blood, like a diffuse alveolar hemorrhage as part of like the autoimmune or inflammatory process? I think is seems to be less likely pulmonary edema. It looks a little more drastic than that. Water is also something to rule out, or just at least, dry lungs are happy lungs, so we want to make sure like water is not a component of that. But then protein, I think PAP can be secondary to a lot of things, and patient will be at risk factors. And then cells, like in cancer. So I think also I see comments in the chat about like how EBV infection could increase the risk of lymphoma or cells filling the airway. I think the possibilities are wide open at this time. I think in terms of the workup next time, sorry, for as a next step, I think in addition to a CT scan, and then sometimes talking to the radiologist is really helpful to kind of help give us a direction of what it could be. And then hemoglobin is not low, although that doesn't really rule out diffuse alveolar hemorrhage, because at least I think 1/3 or something could have like normal hemoglobin. Maybe the patient will get empirically treated for infection, given the, and then getting cultures to assess that part. And I think soon we'll probably start some workup for autoimmune and malignant causes. And maybe down the road, patient would get a bronch. Yeah, I don't know yet, but yeah, those are my thoughts.
Well, amazing discussion so far. You guys are right on track. So for the CTP study that you have asked, I didn't bring in the image, but the radiologist read was multifocal consolidation seen bilaterally with interval small development of the small right lung base pleural effusion that the patient had. They didn't describe any ground glass opacities. So at the end, after all of this data, patient ends up being admitted, and management for multifocal pneumonia was started with cefepime and vancomycin. Then when patient was admitted, this was around 9 p.m., around 1 a.m., patient started complaining of progressive dyspnea and was found to have an oxygen saturation of 85% on room air. He was placed on 4 liters of nasal cannula with only a mild improvement up to 89%. He kept being tachypneic at a rate of 28 respirations per minute, tachycardic at the 140s, and his blood pressure dropped to 97/66. His physical examination this time was a bit changed from the one that was obtained during admission, and this time he was having bilateral crackles heard on auscultation. The night flow team obtained an ABG showing a pH of 7.32 with a PCO2 of 32 and PO2 of 60. Patient kept having increased respiratory distress and low oxygen during evaluation, and he was transitioned then to 8 liters on heated high flow nasal cannula, and his saturation improved to 92. However, he kept decompensating to the point he needed heated high flow in mat settings, 40 liters and 100% FiO2. At the end, patient was tiring out and he was transferred to the ICU for intubation. The X-ray obtained, if you can show it, yes. Basically, the radiologist read is that they are concerned now of increased multifocal aerospace disease concerning for ARDS. So with this data, guys, anything changes in your differential?
Yeah, thank you so much for. I'm so feeling very bad for the patient because now he was sitting, he was at the floor with his hemodynamic stable. Now he's suddenly decompensated with low blood pressure and some tachycardia and requiring high flow oxygen saturation, shifted to the ICU. I'm just wondering whether now this kind of infection slash inflammation is disseminating to the entire body, where body is unable to cope up with the infection load, leading to kind of any kind of septic shock. I really don't want to be aggressive saying it could be septic shock because I didn't hear the patient had any fever, but his shortness of breath is so severe that he is landing in respiratory acidosis, which is required, requiring any kind of aggressive oxygen management. And also, as you mentioned, it could be ARDS, but I'm just wondering whether the kind of infection now draining all the kind of pus into the alveolar tissue, or bringing a lot of inflammatory cells like neutrophils or any kind of macrophages into the lung interstitium, or it could be any precipitating heart failure causing bilateral crackles. So those are my thoughts, but I really don't know whether high resolution CAT scan is going to help in this situation. But I'm just curious to know what is the lactic acid, and what about the creatinine, to just look for any ongoing multi-organ dysfunction, and any kind of LDH to look for any cellular proliferation. Yeah, so those are my thoughts. I love to hear Anmol and Dr. Mengi thoughts as well.
Wonderful thoughts, Rahul, as always. And I think um, as we were going with the case, the antibiotics were changed and the patient decompensated. Definitely, the one thing that comes to my mind is that blood pressure is dropping and the patient has inflammatory signature there. So the patient is going into shock, and probably the cause for that is sepsis, looking like sepsis. Definitely, I want to look at the lactate levels for sure, because they will be most likely to just understand how the patient is progressing with the treatment, as I believe that in such a condition lactate might be rising, and there might be resulting AKI, resulting in elevation of creatinine. And if we see that the patient also went into acidosis, so I believe that definitely the patient is getting sick. And yes, the main thing I want to talk about was ARDS, acute respiratory distress syndrome. So what could be the cause for that? Maybe sepsis could lead to that picture. So that's what I'm thinking. There is some pathology which led to the patient developing ARDS. And what would we do next? I believe intubation is also risky in such circumstances. When we give sedatives, the blood pressure, patient already blood pressure is very low, and the blood pressure actually drops. So definitely the intubation is very risky in such circumstances. But after that, regular suctioning of the patient, and if the patient stabilizes, then maybe pleural tap can be performed for the pleural effusion that has been mentioned. So that's what I'm thinking. But let's see if that also, the one more thing is that if the patient improves with the antibiotics which are now being prescribed, cefepime and vancomycin, that also I will be looking out for. What do you think, Dr. Mengi?
Yes, I agree. And I think just wanted to reflect on one management thoughts here is that I like Rahul, you mentioned earlier about how the X-ray looks so discrepant from the vitals. Yeah, and then I think in reality, I think in a young patient, relatively young patient, I think they have pretty good lung reserve, but then they can really decompensate quickly. And I would imagine this case would be one of those. And so I think it's super helpful in this case where the team promptly intubated the patient, because my experience that this could be like a really high risk situation where sometimes when you intubate, if you intubate a little bit too late, then they could develop PA arrest during intubation because of the degree of hypoxia, because intubation is a really high risk procedure in this kind of acute setting. So I'm glad that the patient was able to be kind of stabilized with the intubation, which will allow the next step, which is to do like a bronch to kind of clarify what is in the airway. So I think I love that was happened to this patient. Hopefully that will help clarify. And then I agree. I think with the hypotension really makes me think about, like, we have to cover the infection, the sepsis part, which patient is already covered with vanc and cefepime. But I think we usually in this setting, like we broaden the coverage by adding, like we could consider broaden to Zosyn if we're concerned about any anaerobe scenario. But I think more so like we would add atypical coverage like azithromycin. I think it's better for Legionella, or doxycycline. You can choose one of them, because I can see like Legionella could potentially present this way, even though I don't know if there's hyponatremia and any other clue. But I think Legionella could definitely present kind of aggressively. I would like cover those. I think that's left with some more chronic or less aggressive infectious causes like fungal, or I don't see clear risk factors for that, I guess. But I think that one then Bronk will help clarify that. But at least broad spectrum antibiotics as well. And then I was thinking also like what other treatment we could offer to reverse. I think in the setting of such, ARDS, steroids something that comes to mind. And what you're treating with steroids is if there's concern for either like diffuse alveolar hemorrhage or certain ILDs that are aggressive, which includes acute interstitial pneumonitis and like I think cough sometimes can be a little acute and could be reversed with steroids, and then eosinophilic pneumonia is another thing. Like even if you don't see eosinophilia in the peripheral blood, like you can still not rule out like eosinophilic pneumonitis. I'm wondering if there's another thing I'm missing, but I think steroid is something we empirically treat with to prevent mortality while we do workup of to figure out what is going on in the airway.
Yes, and probably to add, I think it must have been done, adding the inotropic management, adding the inotropes to the patient would also help in this case.
Perfect. I love where this discussion is going. So to give you some data, patient lactic acid was 1.3, and patient kept maintaining the same blood pressures, soft pressures of 100/60. So patient was actually never on pressors at the end. Team ended up consulting ID, and ID decided to continue the same antibiotics with the addition of azithromycin. And patient was also started by high-dose prednisone 80 milligrams while being in the ICU. In terms of the infectious workup, it's a long list, but just a disclaimer, everything came back negative. So HIV was negative, MRSA PCR negative, strep pneumo, Legionella negative, influenza, RSV, COVID-19 negative, respiratory viral panel negative, blood cultures negative, lower respiratory cultures negative too, EBV IgG antigen positive, IgM antigen negative, Aspergillus galactomana negative, PJP negative, coccidioides antibody negative, strongyloides negative. There was a concern for TB, but the AFB stain was also negative, and patient had an ESR elevated at 90. Also, bronchoscopy was performed in his first day in the ICU, and the ground state didn't reveal any microorganisms, but there were few PMNs in the BAL fluid sample. So after seeing this, anything changes in your differential?
That's great that the patient is improving with mechanical ventilation and the vasopressors were not needed. I believe that ID workup has been negative, but there is definitely some inflammation, no doubt about that, with the raised inflammatory markers. And AFB stain, I don't know what stain was done, but smears of the AFB smears are not very sensitive and specific. So if the patient was in a TB endemic area, definitely those TB PCR tests would have been sent. And as I said, probably the pleural fluid, if we can take that out, maybe analyze that can help. Other than that, what do you think, Rahul? What adds to your differentials?
Yeah, I really loved your thoughts, Anmol, for in looking for the TB sensitivity. And I'm just curious, we thought initially I thought infection could be a possibility, but all of the infections when it came to be negative. But I'm just still figuring out whether this could be any possibility of underlying inflammation precipitating the symptoms. Like, for example, eosinophilic vasculitis or Stress syndrome, or with granulomatosis eosinophilic granulomatosis, where we have not only the lung involvement, they're going to have concurrent renal involvement too. I'm just curious to look for the urine analysis, whether how much is urine is making, any oliguria or any kind of hematuria or any kind of RBC cast, to just look for any any kind of ongoing pulmonary renal syndromes. So that could be a possibility. And other than that, I really don't know whether because he shortness of breath is has improved, and despite I'm just curious whether because he's on all kind of possible antibiotics. I just want to curious to know whether his shortness of breath has improved or not. If he's not getting improved, it means I'm not targeting the underlying etiology. Now I have to look for other any kind of autoimmune workup, because there's a possibility of autoimmunity in this patient because he's in a middle-aged man. So I just want to look for any kind of Pianka, Sianka, any kind of anti-double stranded DNA. So those were my thoughts. Yeah.
Yeah, I love all your thoughts. Yeah, I'm really stumped right now. I was wondering, yeah, because I think I would love to really better understand the bronchoscopy, the BAL analysis. If there's like, sounds like there's few PMNs, which would be a little discordant with our thinking that there's a lot of inflammation in the lungs. But I wonder if there's any differentials for those PMNs to kind of help guide. Also, like sounds like we've ruled out like hemorrhage and even proteinosis. I wonder if there's like a milky appearance or any rich protein in that. I think some additional serologic workup would be helpful in terms of assessing some of the autoimmune etiologies. I think I'm less familiar with like the BAL analysis for those conditions. I have to like look up my notes to kind of find more patterns. But I also love certain thoughts like, could this be a effect of vaping or things that I feel like sometimes those things can cause like a very acute course like this, like it's possible. I wonder if the BAL is really non-revealing. I would definitely talk to the pathology or to consulting our pulmonologist for sure regarding the interpretation of that. But I wonder if it's really not revealing them, the patient might matter whether he'll need a biopsy or something as a ultimate way to diagnose. But I would at this point really consider empirically treating with a high dose steroids and assess the response. But I would of course talk to our pulmonologist first. Yeah, I
Okay.
think those are the thoughts that came to mind.
Fair enough. And actually, patient ended up improving with the high dose steroids. Therefore, rheumatology was immediately consulted. Before consulting them, we obtained an UA, and the UA basically didn't show any eosinophils, and it showed only hyaline casts. Otherwise, it was a really unremarkable urinalysis. So, autoimmune workup panel was ordered, and ANA was positive with titers of 1 to 320 and speckled pattern. C3 was normal, C4 was normal, Pianka negative, Cianca negative, RF negative, CCP negative, anti-centromere antibody negative, anti-dsDNA antibody negative, anti-JO1 negative, anti-scleroderma 70 antibody negative. Then rheumatology decided to add more workup, including chromatin antibody, which was negative, RMP antibody, that was also negative, a Smith antibody, that was negative, phospholipid and cardiolipid antibody, negative, hexagonal neutralization, negative, lupus-sensitive APTT, negative, dilute Russell Viper venom, negative, fibrinogen was negative too, was normal in the 350s, thrombin time, normal, beta-2 glycoprotein antibody, negative. So rheumatology decided to continue patient with high-dose prednisone on 80 milligrams and also offered the Bactrim prophylaxis for PJP. Also, more imaging as a follow-up was ordered. Patient ended up being self-extubated 5 days after being intubated and was placed again in heated high-flow nasal cannula, but he was successfully able to wean off to only high-flow nasal cannula. A repeated CTPE study that we obtained showed only redemonstrated multifocal airspace disease that appeared to progress from the prior study. And now this time he had a near complete consolidation of the right middle lower lobe pleural effusion. An echocardiogram was obtained showing an ejection fraction of 62% and some mild pulmonary hypertension with an RSVP of 48. So given this rheumatologic data and new imaging, where do you guys stand now in your differential diagnosis?
Yeah, honestly, I feel it's one of the challenging cases I've ever encountered because I thought it could be infection. Now it's not an infection. Now I thought it could be inflammation, and almost all the available autoantibodies on the earth all came to be negative except ANA. They generally say the ANA 1 is to 320. I mean, anything greater than 160, we can consider positive. I'm not sure because there is ongoing infection/inflammation. Am I really going to rely on this ANA? That could be my query. But again, I'm glad the patient got extubated and doing fine. And all of a sudden, again, the CAT scan is showing the multifocal airspace disease and consolidation of the right lung, right middle lobe. I'm just curious, though he was on steroids and antibiotics with all the possible of prophylactic medication, he's still decompensating. I'm just curious whether I'm missing anything, and also there is ongoing pleural effusion. Uh, and definitely because based on the echocardiogram, I can rule out there is no other cardiac history going on, which is precipitating the pulmonary pathologies. So I strongly believe that is there something going on. Now I'm focusing more on the lung pathology, and I mean none of the bronchial lavage did not help me in framing the differentials. Now maybe I would go with any kind of thoracocentesis to look for any abnormal cytology cells, what are the protein and glucose, any kind of abnormal cells. And if I still have any queries, once the patient gets stabilized, I'm not sure whether to go for the lung biopsy to have the gold standard definite diagnosis of to look for any kind of inflammation mediated uh, pneumonitis, something like that. So those are my thoughts. I would love to hear Anmol and Dr. Ming's thoughts as well.
Wonderful thoughts and an amazing, amazing case. I'm honored to discuss that. And what I'm thinking right now is one of the amazing things in medicine is response to treatment. When we treat with some medications and the patient responds, that just magnifies our diagnosis. So definitely, we need to rule out some important infections before starting the patient on steroids because otherwise the patient will flare up. So now this patient improved with steroids, so the infection bar goes little down. And with that, I think the autoimmune panel we have ANA is positive. I would say I have limited knowledge on what should be sent next in the autoimmune panel workup if we are considering an autoimmune etiology. But I guess the mild pulmonary hypertension. I think all the categories we have of the pulmonary hypertension, I would want to understand which category does it fit. If it's like what is it? It just reminds me of a case I recently saw in the hospital. I'm sure it's not related, but the lady, she had underlying connective tissue disorder, and she also had chronic thromboembolic pulmonary disease leading to the pulmonary hypertension. But sadly, she expired. So I was just trying to correlate this case with that. And but yeah, definitely, the patient is improving with the treatment we have started, high dose steroids. But then what next? That is the question. Maybe continue with this treatment and consult the physicians, the rheumatology ID as to what to be sent next. I think that's where I am, and would love to learn from Dr. Mengu.
Oh, I'm learning so much from you, and I love how you have commented on the treatment response as a clue for diagnosis. And even though although I don't know the diagnosis, but I think that would help us narrow down the differential diagnosis, which includes, I think that would include some of the acute ILDs that was mentioned earlier. I think another etiology I've heard, or I was thinking, includes like lymphocytic pneumonia, which can be associated with Sjogren disease. It may have like more cystic patterns. I don't know, but I was thinking I would also want to test for Sjogren because here I think the ANA of 1 to 320 is like, we know ANA could be non-specific, but 1 to 320 in the male is a little bit abnormal. So I wanted to kind of see if there's any like additional serologies as part of the ANA, like an ENA panel, to see if there's any additional antibodies, especially like Sjogren here. But also, like, the other finding that caught my attention is the consolidation. Sounds like there's like a persistent consolidation in the right middle lobe, which, because if there's like you would imagine like whatever inflammation would improve with steroids, but there's still this right middle lower lobe consolidation. So that makes me wonder, first it could be like part of like COP or cryptogenic, like organizing pneumonia, or secondary organizing pneumonia, which could mimic pneumonia, so like having consolidations in the lung. And that's one thought. And the other is whether there's like some airway problem in the like endobronchial lesion in that right middle lobe causing this persistent consolidation. And for like diseases that involves airway, I think I don't have a robust illness, or I may have a illness script, a differential at some point. I couldn't find it, but I was thinking like some like IgG4 or and certain infections like TB, that's also like in my mind, could like, and then IgG4, I think some others are could have like endobronchial lesions. So I wonder if that's a clue, or is that like just like a residual finding during the course of treatment. So those are the thoughts that came to mind. Yeah, I would love to learn from you, Marino.
Okay, so amazing discussion so far, guys. I think you have covered all the possible bases that we were thinking about at that time in the hospital. But this is going to be the final aliquot. So patient ends up being discharged because he was successfully weaned off even to the high flow nasal cannula, and he went home on 4 liters with home oxygen after completing a 12-day course of high-dose prednisone with close follow-up with rheumatology to complete the autoimmune workup, which at the end was inconclusive. Then 4 days later, after being discharged, patient gets readmitted to the hospital, and he was found to have again accumulating pleural effusion. Pulmonology was consulted and offered the patient a thoracentesis, but he preferred to hold off of this and asked to be transferred to a tertiary hospital. Then patient gets transferred to the tertiary hospital. He's still admitted there, and we have access to the outside records, but we don't have the complete information. But we were able to obtain the diagnosis the patient obtained there. So upon reading the outside records, patient underwent CT abdomen and pelvis study with contrast that showed findings of carcinomatosis and diffuse abdominopelvic adenopathy, as well as presumed osseous metastatic disease with osteolytic lesions in the femur and thoracolumbar spine. Patient also had findings were indeterminate to look for the primary malignancy, but there was some focal thickening of the sigmoid column with questionable soft tissue mass that could be representative of the primary neoplasm. Then patient ended up going for thoracentesis in the tertiary hospital, and it showed mixed cloudy and bloody fusion with 71% monocytes in the differential. Then sadly, we don't have more access to confirm how patient has been doing so far. But according to what I checked just this morning, patient is still admitted and has had a very difficult hospital course so far. And that's
Wow.
all the information I have for this patient.
That's an amazing case, Marino. I mean, I was surprised for some time. This is something which we had to consider, the malignancy part, and I think that the amazing thing about CP Solver's VMR is that when we get to learn from such cases and we reflect upon them when we see the patients the next day in the hospital, I think that's what I do every day at CP Solver. So thank you for bringing up this case and for allowing me to discuss that. I have learned a lot, I'm still amazed by the diagnosis. Thank you for sharing that.
Yeah, wow. That's such mind-blowing outcome, and really feel bad for the patient for having such a significant underlying diagnosis. Although I'm still trying to put together like how the carcinomatosis have like how is that related to his first presentation, like through what mechanism? Because yeah, I wanted to hear your thoughts, Marino, like how that carcinomatosis, is it part of the lung? Is it the first episode, like the lung manifestation, or because I think if we did bronch and there's no, I assume they did cytology and it wasn't reported.
Yeah.
Yeah, I'm curious to hear how you put together, but that's such
E-
a mind-blowing case. Yeah.
I mean, it was very mind-blowing, and this was about maybe 1 or 2 months ago that I had this patient, and I have reflected a lot back in this case. Um, and I ended up like doing a little research on what is the relation between cancer and ARDS, and I found that normally we have the common culprits of ARDS. Most commonly sepsis, we would say it is in almost every hospital system. However, cancer is also an independent risk factor for ARDS. So I think that's where we can tie the carcinomatosis and the ARDS, because usually how cancer was associated to ARDS before is as cancer causes immunosuppression, then this immunosuppression can predispose to infections and therefore ARDS. But I think in the case of this patient that all infectious workup was negative, and when getting to the review of systems, that patient, although he said it was intentional weight loss, patient had more than a 50-pound weight loss in over a year that he attributed to changes in diet. And then this also made me wonder, how should we tackle in weight loss, even if it is intentional or non-intentional in the patients. Also, I think after reflecting back I think in the hospital, we did a lot of anchoring when we heard about the trip to Bermuda. It was like, oh, this gotta be something infectious. Like, it fit the picture that patient returned from Bermuda and symptoms just started at this time. But what if the patient was experiencing the symptoms and he were just downplaying them because he felt at that time that he could be doing whatever he wants. And in my case, I got the patient right after he was downgraded for the ICU. And I would say that I really anchored a lot on the vaping history. When I read and then I read the bronch report. Normally in E-Valley, when you get a bronch, you can get some eosinophils, but also the time lapse. There are not enough studies of E-Valley. So for E-Valley, the time lapse or the time of onset from last vaping time to develop ARDS is 3 months. So last time patients vape was 8 months ago. So that basically could have ruled out E-Valley in this case. And my last reflection on this case was, patient likely presented with a colon cancer at the age of 38 without any family history on it. And that just makes me reflect back to the updates that have been made to the colon cancer guidelines. I remember when I started studying to start my journey to go to the United States, initial age of screening was 50, and now we're doing it at 45. So now every day we're seeing more and more frequent cases of colon cancer. So I wonder if these guidelines are going to be changing in the future too, and we are going to be advancing the age to start colon cancer screening. And basically those were all of my reflections for this case. And until this date, I'm still reflecting to this case, and I'm trying to see what else can I grasp on this amazing case. But I'm really glad of the discussion you had. It was very amazing, very thorough. And I think you were exactly as we were thinking in the hospital when we had this patient.
And I'm
Thank you so
glad you took it. I'm so sorry. Go ahead. Yes.
Oh, go ahead, Barhu. Yeah.
Yeah, I'm glad you took care of this patient, Marino. And I honestly, I never heard about this diagnosis. And everything is a lot of learning points for me. Today, I'm gonna, open the literature and read about the carcinomatosis, and I'm gonna rewatch the video again and reflect a lot on this case. Thank you so much for sharing this case. And it was pleasure discussing case with Anmol and Dr. Mingyu. Thank you so much.
Same. Thank you. And then thank you, Marino, for your such great reflections and sharing with us.
Well, thank you again. I think that, first of all, shout out to Anmol and Raul. Anmol, your second discussion 2 weeks in a row that are quite complex. And Raul, amazing. I really like how thorough you were. Thank you so much, Dr. Mengyu, for coming here and supporting us. Um, Rafa, when he created this residency, IMG Residency VMRs, he had in mind always like showcase that IMGs, we bring a lot to the table. And Marino, this case is amazing. You brought us like a lot of food for thought. How much weight is too much, right? Again, I'm really impressed about how much you have grown, and that will be our first question for you. How have you felt in your residency? What do you think is your favorite aspect of your residency program, friend?
Well, I would say my favorite thing of my residency program is that we are a very close program in terms of how we get along with the residents. Each class has 15 residents, and it's very easy to get along with everybody. I think this program has built a culture of strong camaraderie, I would say, over the last few years. I know it's something very cliche, but you only get to live it when you get here. And in my case, before coming in, I really had high expectations on how would I do. I'm coming to a new system. How am I gonna accommodate myself? And I'm not gonna lie, the first month or 2 months, they were tough because I'm learning a new system. I was off a really big gap period of not training medicine, but I think that being surrounded by the adequate people can help you really fast to improve your skills. And I feel like there's no better place to be for me than this hospital, to be honest.
It's really great to hear that. Do you get like mentorship assigned, or do you reach out to an attending? How does it work?
So we actually get assigned mentors 4 months into residency, and I already met with my mentor. But also we have an open door policy with all of the faculty members that we can always talk with them with any issue.
Oh, that's cool. And I also another very like a common question to ask is like, um, in your program, do you have the possibility to develop research, or is more like um, clinical oriented? How does it work?
So for those who are interested in research, so here in Norwalk Hospital, we are part of the Nuvens Health um, um, network. So recently they started something called Research Academy that is available for interns. It's an 18-month track that basically are for those who are interested in doing research even after finishing their training. But in terms of doing research projects, for example, for those who are interested in rheumatology or GI or pulmonary, that I would say are very strong departments in our hospital. Attendees tend to really offer really interesting cases to present, posters, and whatever you want. So if you are planning on doing research, this is actually a very good place because we also get sometimes really esoteric stuff that you can write cool cases.
No, definitely this one was a very cool case, right? And being mindful of your time, one last question for you is, how do you like the city? How has it been for you? Like, is it like friendly? Do you think we will need like if we get to Connecticut, like need a car, or is like easy mobility?
Well, basically it's a suburb, so definitely you need a car. But if you don't have a car, you are gonna be like you can do all the stuff without a car, but it's gonna get somewhat expensive if you don't get a car. In terms of the people here in Norwalk, I would say people are really decent and amazing. I've never had a problem with someone so far. And for example, I live like 7 minutes. I only do a 7 minute walk to the hospital, and when we go to the clinic, it's like maybe a 15-20 minute walk. I would say in these winter months, it gets a little bit harder to walk because right now the temperature is -2 Celsius. And coming from the Caribbean, I would say this is not my favorite temperature to be in, but you get used to it, I would say.
Definitely. It's good to know for all of our tropical IMGs to be prepared if you're thinking about Connecticut.
But
And
yeah, and also sorry to interrupt, but I
no,
forgot to
go ahead.
mention there is also a very big Latin community for those IMGs who are from the Caribbean or South America. So you could easily find a lot of places that, in terms of like food, that resemble you home, in case you get really homesick.
That's really good to know, especially that having somewhere to get like home food is very important. And again, thank you so much, Marino, for sharing with us an amazing case and your insights about Norwalk and living in Connecticut. I hope that you don't get that much cold. Um, so again, thank you so much. Thank you, Raul and Mo, Dr. Mengyu. I hope you have a great Saturday and yeah, happy holidays. See you.